So we're looking at day 10 here. It says it's the shoulder, elbow, and wrist, but we're gonna cut it at the shoulder because honestly, like we'll mention the elbow flexion extension. We'll move through it pretty quick. We're not gonna spend too much time on the wrist because NASM doesn't test you on the wrist, and they also don't teach anything about the wrist in your either of your textbooks, either the corrective text, like literally any material. NASM doesn't really do wrist stuff, but like oddly enough, they did send us some info in these PowerPoints on the wrist. So, left in the PowerPoint, which is kind of cool. So if you want to know the muscles of your wrist, like your brachioradialis and little things like that, you will have it in here. But we're going to primarily spend time talking and putting notes on the stuff that's like important to this course and stuff that's important to, your tests and stuff. So, looking at the shoulder, so we're gonna see there's a lot of bones today, a lot of joints today. So looking at the what we're talking about the shoulder, the elbow, and the wrist here. Again, primarily the shoulder and elbow, and even the elbow we're gonna move through pretty quick. But you can see when we talk about the shoulder, it's actually the conversation's a little weird because there are actually two things to kind of talk about separately. There's the shoulder girdle and the shoulder joint, and they are two separate things, kind of similarly to how on Friday we were talking about the difference between like your pelvis, which is like where your pelvic bones come together and your SI joint, versus like your hip joint, which is where your femur inserts with your pelvis. Well, the same thing is happening here. We have our shoulder joint, which is where your humerus is intersecting with your scapula. And then we have the shoulder girdle, which is how your clavicle is intersecting with your scapula. One is sort of what gives you, one is your arm and one is what allows your arm to have something to attach to. We look at the shoulder girdle, right? Like we're defining it. It is going to be made up of your clavicle. That's your collarbone, right? So both these like little hard bones you can palpate right here, and your shoulder blade, and that's your scapula on the back. So the clavicle and the scapula. And what we got to remember is that these two things move as a unit. They are totally connected to each other. So like when this, and it doesn't need to move much, but when your shoulder, when your clavicle moves, a little bit, right? Your scapula has to swing with it. And so a lot of times when you see people have like shoulder problems, even things like dislocations and stuff, a lot of times it's because they'll lose mobility in that scapula. And here's what's kind of a fun one. This is my favorite little factoid for you. The clavicle's articulation with your sternum, so like where your collarbone comes together with your sternum right here, that is the only articulation that actually holds your entire arm onto your body. That's the only like bone-to-bone contact that you've got. Your shoulder blade, we're gonna look at this later, is actually considered what is called a false joint. Which means that it doesn't have ligaments that hold it in the back. So the only ligament that's holding this shoulder blade on is actually this little connection right here, which is kind of fun. So that's your shoulder girdle, right? It's like, you think about like a girdle, it holds everything together, right? But then you have your shoulder joint, which is what we're seeing here. And this is where your humerus, your arm bone, is interacting with your shoulder girdle, right? And so like you can see here, if you look at the scapula, see how it's got this little empty space right here. That's called your glenoid cavity. And so where the glenoid cavity intersects with your humerus, that ball and socket joint right there, that's your shoulder joint. So shoulder girdle is the collarbone and the scapula. Shoulder joint is the scapula and the humerus, or the upper arm bone. So very, very common to have stability problems here in the shoulder joint. Again, it is a ball and socket joint. And like I said on Friday, ball and socket joints are great because they have the most range of motion, but with increased motion comes decreased stability. And so it is often pretty common to have stability problems in here. We see rotator cuff impingements, we see dislocations, we see things like that. And so the more mobile of a joint that you have, the more likely you are to have some type of stability problem. And so sometimes the ligaments in here can get pinched, that's shoulder impingement, or sometimes you can even end up with instability, and then some type of traumatic event results in like a shoulder dislocation. Then we get your elbow here. Your elbow's kind of cool. You can actually see it has this little ridge right here, which acts as sort of like this the patella of your elbow. You know, your arms and your legs are very, very similar. It's following the one bone, two bone structure that we talked about. But we don't see like a little floater bone the way we have a kneecap. You know, you don't have an elbow cap, but you do have like a little elbow ridge here. And if you look at how this bone connects, it actually does add mechanical advantage. So like your triceps will wrap around here and insert um, onto your radius here, and then that allows you to actually perform elbow extension. And so you can see primarily this joint right here is a hinge joint, but you can also see how your radius and your ulna are interacting with each other right here. I think I might have just said radius a second ago. I meant ulna. You actually see right here, this little ridge, that is what allows like pronation and supination to happen. And so, you know, in a supinated position with your palms facing forward, that anatomic position, these two bones are sitting kind of like this, but when you rotate your forearm palm down, that actually creates a twisting motion. So they kind of almost like DNA strands, right? Like they make that little, almost like a helix. And so, you know, they'll cross over each other like that. And that's why this is a pivot joint, whereas this is still a hinge joint. And then you can see in your wrist, you've got all these individual little joints here. I think that may be another reason why NASM doesn't go over this, because it's just very complicated. There's a whole bunch of little bones here. So you've got all of the carpals in your wrist, you've got the metacarpals of your palm, and you've got your digits making up your fingers. But you can see like this little joint right here, which is your distal radioulnar joint. You know, there's a radioulnar joint here where your radius and your ulna are sitting into each other. That's the pivot joint we just got done talking about. And that's the more proximal side of it. But the more distal side, you can see there's another like place where they come together. Again, very similar to how your tibia and fibula had a joint up top, but they also had a joint down below. So we can see that arrangement again in the wrist here, and a lot of like, you know, fascia and stuff holding those bones together in the middle. So looking at our shoulder injuries that are very, very common. Oh, and then just really quickly, I guess I got the definitions up here. So your shoulder girdle is your clavicle and your scapula. They move as a unit. Your shoulder joint is your humerus and your scapula, which is the most mobile joint in your body. Again, it's a ball and socket joint, so it can perform every motion, what we call circumduction, right? So that's flexion, extension, abduction, adduction, internal rotation, external rotation. It can perform all those, right? But we do know that with increased mobility comes decreased stability, which is why we definitely want to be familiar with shoulder injuries so that, you know, we can help our clients avoid those. And then you get your elbow, which is between the articulation between your elbow proper and the radioulnar joint. So that's the entire elbow there. The radioulnar joint is the pivot joint. The elbow is the hinge joint. And so that's the humerus and the ulna, and the radius and the ulna. So looking at shoulder pain here, looking at our common conditions, symptoms, diseases, whatever you want to call it. We can see shoulder pain exists in about 1/5 of the population, pretty common. 40% of those injuries will last greater than a year, and it costs $39 billion per year. It actually is one of the most expensive injury types just because of how complicated it is to fix. And so shoulder impingement, very, 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 very common. The most prevalent diagnosis that we're going to see in 40 to 65% of cases, those are often shoulder impingement. And shoulder impingement, which I think I'm going to see a good picture of here. Yeah, you can see shoulder impingement is basically right here, where you remember I mentioned how bursa, right? They're basically these little fluid-filled sacs. So you'll have like ligaments, or you'll have like you can see a tendon here, right? So you see this like this muscles, tendons running around. If you lose mobility and your muscles start passively just pulling all day long, right? We know that's kind of what we're talking about. We talk about like an overactive tight muscle, right? It's a muscle that's staying in a shortened state. It contracted, now it doesn't want to relax, right? And so you'll often see in that is you'll see decreased ranges of motion. So you might actually get a pinching between bone to bone, and then like these soft tissues, which are supposed to be there for to prevent friction, start getting pinched, and it can become very, very painful. It can lead to like bursitis of the shoulder, which is basically where, you know, these little fluid-filled sacs actually pop. You can see tendonitis, obviously very, very common. You can see like ligament tears, all these different injuries. And so, you know, the most prevalent is going to be that overactive muscles leading to just poor posture and impingements. But we can also see like traumatic shoulder dislocations that can be very common as well. I had a client dislocate their shoulder once. It was the worst thing. Just this older gal was just like running. She just was trying to jog around, like take a photo of something, and she just slipped on the floor and just like landed right on her shoulder and totally dislocated it. Her name was Betty White, by the way. I don't normally like reveal clients' names, but I don't think anybody's going to find out about it in this case. But her name was Betty White. She was not the Betty White, but she was a Betty White. Really nice lady. We ended up working on her shoulder. You know, she had to go through physical therapy and rehab and stuff. But then eventually she ended up working her way back to the resort, and so we'd work on, you know, creating shoulder stability after that. Love Betty White. Never have I seen anybody in my life who disliked eating her vegetables more than that person. It was like a little kid trying to get her to eat vegetables. Shoulder pain, very, very common. Then we do see just degenerative changes as well. You know, like we're going to see like the cartilage wear down. We're going to see, you know, arthritis and things like that in the shoulder as well. So we also see elbow, forearm, and wrist injuries. You know, that's about a third of work day illnesses. A lot of times you'll see things like carpal tunnel syndrome. You'll see like elbow tendonitis, things like that. Very, very common in like desk injuries, like lateral epicondylitis, more commonly referred to as like tennis elbow. You'll sometimes see like medial epicondylitis as well, which is more commonly referred to as golfer's elbow. Both those are just basically, you know, anytime you see that itis, right? Inflammation problems. And so you see like, you know, soft tissue rubbing on hard tissue, which causes inflammation, which causes like swelling, which causes pain. So a lot of times we know that there's a lot of like repetitive tasks and things like that. And so, you know, we want to come up with injury, you know, injury treatment strategies. So elbow pain, general pain in the elbow region, usually associated with repetitive tasks. Shoulder impingement, that is actually the pinching of connective tissue in your shoulder joint. Again, that often leads to inflammation, which decreases your range of motion, right? Also very associated with repetitive tasks, usually associated with like overhead reaching tasks. So, you know, we talk a lot about like sedentary lifestyles and how those have like a lot of injuries, right? Like carpal tunnel syndrome, we see rounded shoulders, things like that. But shoulder impingement can be very common in like very active industries as well. You know, we see it a lot in construction workers who do a lot of like overhead reaching movements. You would think that like if you were a painter, right, like doing this kind of motion all day long, you think you'd get really good at that motion, but what ends up happening is it actually tightens everything up, and then eventually it becomes very difficult to raise that arm up overhead. So shoulder impingement, very, very common as well. We're going to see rotator cuff tears. This is incredibly common, incredibly common. So these are strains, tears, or ruptures in the muscles that make up your rotator cuff. And your rotator cuff are basically these muscles that help you perform external rotation. So you'll see people have decreased ability to externally rotate their arms. Very common, very painful injury. And so a lot of times we spend so much time internally rotating, we get bad at externally rotating. And so that's something that we kind of want to work against, right? And so it's a lot of times we'll do a lot of rotator cuff strengthening exercises, things like scarecrows or external rotations, you know, YTAs, things like that. Then we're also going to see things like I said, dislocations or subplexions, where you see like literally you will move this joint out of its socket and it will no longer be connected. Pretty friggin' painful injury if it did cause any damage to any of that soft tissue on its way out. Because if you actually look at it here, if you look at like your shoulder joint, if you look at the ligaments, there's a lot of soft tissue ligaments that are holding everything in place. You can see all of that here, right? And so you know, if any of that gets torn during that subplexion, what can happen, or during that dislocation, what can happen is it can require surgery in order to need to be reconnected. And so it's rare, but it can happen, you know. Tennis elbow, like I said, lateral epicondylitis. That's going to be this kind of general aching on the outside of your elbow there. Highly associated with like tasks where you are doing things like a big backhand. So that's why it's tennis elbow. But we will also sometimes see medial epicondylitis, which is golfer's elbow, and that's associated with pain on the inside. So you'll see like a lot of swinging motions here with like that big extension, and you know, golfers often perform like kind of hyper supination, and so you'll see this sometimes. It's definitely less common. There's more space here, you know. There's less space here, and this is definitely like a harder bone. Well, not harder. It's not a harder bone, but it is like more likely to rub than it is to rub here. And so definitely more common on the outside there. And oftentimes what you'll need is just a little bit of massage in the elbow, which you think massage would sound good, but it's pretty painful. Same thing is true. I actually think golfers, like the massage on the medial side, is way worse. I don't know if that's just because like I happen to be tight on this side and maybe I'll get golfer's elbows someday, or what. But I find that the medial massage, like on this muscle right in here, is way worse, personally. We will sometimes see carpal tunnel syndrome. This is kind of an interesting one. Carpal tunnel syndrome, swelling or inflammation that can put pressure on what is called your median nerve. And it's this little nerve that runs down your palm before spreading out and, you know, controlling your hand. And so what will sometimes happen is you will get inflammation on this little ligament right here, and it will tighten up, and then that will start like pushing on that nerve. And whenever you touch a nerve, obviously you experience a pain sensation, right? Remember on Friday we were talking about piriformis syndrome, where that tight butt muscle sometimes touches your sciatic nerve. So people will get sciatica or piriformis syndrome. Very similar to carpal tunnel syndrome. Basically, only that's a muscle, but this would be like the fascia of the palm actually gets tight. So the old carpal tunnel surgery was intense. Carpal tunnel surgery. It used to be really intense. They would go in and just basically like flay your whole hand open, and you'd be left with this pretty large scar. Let's see if I can. Yeah, used to look something kind of like this. Pretty big, right? Nowadays, they can go in there with this little itty bitty one. They do it like all arthroscopically, and this little itty bitty tiny little scar. They go in there and they basically just open up that cavity, make the tunnel a little bit larger, and that way the nerve can't get poked anymore, and so the pain starts to go away. So this is kind of funny. I will probably have to deal with this at some point. I will probably have carpal tunnel syndrome at some point in my life. And it's funny because you can actually see it right here, because something that runs on my dad's side of the family, most of my problems I get from my mom's side of the family, but one thing that I get from my dad's side of the family, we have this really weird genetic condition called a Dupuytren's contracture. This is fairly rare. You're not going to hear about it too often, but what it is actually, for some reason, the fascia of the palm starts tightening up. And if you were to go look at my dad's hand right now, his hand is actually stuck kind of like this, where like he can extend these two fingers just fine, but the fascia controlling this one especially, his ring finger is like stuck down like that almost entirely, and then his middle finger just a little bit. So he looks like he's like almost doing like a half Spider-Man thing. But his fascia on his palm is super tight, and it happened to my uncle, his brother as well. And what it looks like is this. It's kind of interesting. And what you see is this little, whoops. Oh man, that's terrible. Yeah, there we go. You see this like thick band right here? It basically tightens up. This person's still keeping their hand nice and straight. But you'll see this line, especially, yeah, right there where this finger basically gets stuck. And my dad just needs to go get surgery for it. I mean, like, it's not that big a deal actually. But he's such a chicken that he hasn't gone and done it. He's a real baby about getting like go get his surgery. but it is it's sometimes called it's called palmar fibromatosis or a Dupuytren's contracture, because it's named after this French surgeon who was Napoleon's surgeon, actually, something Dupuytren. But basically, there's a couple different treatments for this. I'm sorry I'm taking time. This isn't super important, but the treatments are really cool for it, where basically they'll either go in there, they got a couple. One of them is they'll take a needle and they just basically poke it a whole bunch, kind of like an ice pick, until eventually it breaks up all the fascia and then your hand relaxes. Or they'll go in there and just cut it like a traditional surgery. Or there's a new thing that they are trying, and if I ever get this is what I want to do, where they inject your hand with a flesh-eating bacteria, and then they leave it for like 24 hours, and it basically just eats away at all the like fascia, and then they like, you know, inject like an they kill it, so it can't keep eating your hand. But I was like, that sounds super cool. But that's what's called a Dupuytren's contracture. My dad has it really intensely, and when I broke my hand 2 years ago, I had to have my hand in a cast. And it a lot of times people will get this when they work like, you know, really heavy like construction jobs and stuff. But you'll notice actually, if you look on the camera there, do you see how like you can see that kind of thick band on my finger? That's the band that, yeah, it really shouldn't be that thick, but you can kind of see it. The reason it has like that big dent there is because basically it's a little thicker than it really should be. So that'll be something that, you know, when I'm like in my 50s, I'll probably have to go get like a surgery or something. So anyway, kind of a fun one for you. There's there's the weird disease of the day. Let's go ahead and look at our bones here before we move, you know, let's move out, we'll move out of our conditions and syndromes and stuff and move into our bones here real quick. So quick bone word anatomy that we've got. You've got right here, this is your manubrium, which is the top portion of your sternum. So when you think of your breastbone, right, it's kind of this big dagger-shaped bone here in the center. The very top of it is your manubrium. That's the section there. And then a lot of times people will refer to this as the sternum. Technically, the sternum is here in the center. Your manubrium is like the little, it kind of looks like Superman's shield in a way, right? Little shaped at the top here. So then you've got your collarbone, which you can see connects right here up top, right? And so like this is your collarbone as it runs across. And so what you have here is what's called your AS joint, right? This is your anterior sternoclavicular ligament, right? And so this is sometimes referred to as your SC joint as well. And so that's the sternoclavicular, where your sternum, I know it's the manubrium section, but it comes together with your clavicle. Then over here, you have your AV joint, which is your what's called your acromioclavicular joint. And the reason it's called that is because if you look at your scapula by itself, I'm just going to pull up the scapula. If you look at your shoulder blade all by itself, here's a view from the back, right? See how like the spine of your scapula comes around and then it has this little hook. And so there's a picture of it from behind. Doesn't really look much like a hook from that angle. Oh, look at that. There we go. 3 pictures. But take a look here. You can see there's the hook as it comes around, right? See how it kind of hooks around like that? Like there it is, right? It's working its way to the front, and then there's the front there. And you can see it from the side, that right there. So this little like projection right here, that is called your acromion process. So this little like notch on the bone here is your acromion, right? And it's basically where the spine of your scapula, which is this ridge here, hooks around to the front of the body. Okay, then you've also got on the front here another hook that goes the other direction, right? So you got one hook coming around this way, and you got another one. Actually, I got the wrong angle here. It comes along this. Oh God, that way. There, my thumb will do it. So one hook that hooks like that, and another one that hooks away like that. That bottom one is called your coracoid process. Okay, so let's go back to our pictures here. So there's the coracoid process, right? And there's your acromion process. And where your acromion process comes together with your clavicle, we call that your acromioclavicular joint. which is super hard to say. And totally what I had to say a million times during my interview to get my job at Sochi. You guys are actually looking at the PowerPoint that they gave me in order to do my interview to get hired. And it was horrible. So there's the anatomy of what we're seeing here. We've got the sternum, the collarbone, and the scapula, right? And so like those are going to be held together with little ligaments where those bones all come together. And then this little dent right here, that's your glenoid cavity, and that is where your shoulder joint sort of inserts. And that's where your arm sort of attaches to the rest of your body. So again, shoulder girdle, right? That's going to be your sternoclavicular joint, which we're going to see here, where your sternum comes together with your clavicle. Your acromioclavicular joint, where your acromion process, the notch on the back of the scapula there, comes together with your clavicle. And then technically there's one more joint here called your scapulothoracic joint, which is not even really a joint, but it is where your scapula, so look at like scapulothoracic joint. This is what is referred to as a false joint. And the reason it's a false joint is because it's not held together by being a bone-to-bone connection, and it's not held together with like ligaments. So it's not really a joint, technically. We just call it your scapulothoracic joint, and it's basically the space between where your scapula is interacting with all your ribs in your spine. So that little gap back there, you can even dig your hand into it. You know, you can't do that with any other joint in your body. So like you can reach your fingers in there. That's your scapulothoracic joint, right? Actually felt really good. So that's what we're seeing right there. Where your scapula is interacting with your thoracic spine, basically. And so there's all your scapulothoracic motion, right, that we talked about early on in this class, right? Elevation, depression, protraction, retraction, and then upward rotation and downward rotation, which has to happen in order to allow your shoulder joint to do abduction and adduction. Your scapula has to swing a little bit. It has to allow that gap. You know, it's like holding it there the whole time. And so there's a little rotational movements that happen in your scapula, which is also a reason why that's a false joint. We don't want that to be connected with ligaments, because then, you know, this bone wouldn't be able to move because like the scapula would be too held in place. So looking at that shoulder joint, right, looking at that ball and socket joint, you can see all the ligaments that are holding the whole thing together here, right? Now this little gap here, you know, this little like gap between where your acromion process hooks around, and then this little like ridge that's right there, this is referred to as your glenoid cavity, okay? It's this little gap, and that is where the ball and socket joint actually interacts. So you'll sometimes hear this referred to as like your glenoid cavity, right? And so like that is where the head of your humerus comes together. Now, obviously this is really smooth here because it needs to be able to actually like move around, and we don't want it to get like caught on anything in there. We want it to be, you know, have a nice smooth, you know, ride as it's going through its full range of motion. But notice how there's this notch, this ridge right here. That's actually where all the muscles in your shoulder joint that are allowing you to do abduction attach. These little tiny muscles will run back here and they'll grab onto that little ridge. Not a very big place to grab onto a ridge, right? And yet we see freaking gymnasts doing like that iron cross move, right? Where they're on like the rings and they raise themselves up like this. Little itty bitty tiny attachments right there. It's amazing, right? Again, that kind of goes back to looking at levers and how amazing they are at being able to produce movement. So that's sort of like what we're talking about right there. And then the muscles that rotate that humerus, you know, pulling it this way and this way, those are the muscles of your rotator cuff that allow that to happen. So what's fun is like these ligaments kind of sit here in sort of a relaxed position until you get into these big ranges of motion, and then they slowly tighten up. And that's why usually you don't hear about people like, you know, we don't experience a lot of shoulder impingements or shoulder tears or anything like that when you're resting your arms here. It's always like when somebody's like reaching for their coat in the back seat or something, and then all of a sudden they're like, ow, my shoulder hurts, right? Little like extreme ranges of motion. That's the only time we often hear about like injuries and stuff. Then we get your elbow here, right? That is your humerus, which is your main upper arm bone, and then you've got your radius and your ulna. So your ulna is where you'll actually have like the ridge that comes around, like your elbow proper that you can feel. That is the bottom part of your ulna. And then you've got your radius on the other part of it, right? So that's on the inside there. And so, you know, again, this is a pivot joint, whereas this is acting as a hinge joint. So you can see it right here, right? So there's the elbow proper, right? That's at your ulna. And then there's your radius right there. And if you have ever smacked yourself right here, a lot of that is actually, you know, they call it your funny bone because it's named after like where your humerus is intersecting with your ulna. To be fair, you didn't even hit the humerus, even though it is the funny bone. You hit the ulna, but what you did is you smacked what is called your radial ulnar nerve, and it does not feel awesome. I hit it yesterday while playing spike ball, and I was like, my arm's dead, and I had like to take like 5 minutes before it came back. I hit it really hard. So that is the articulations that you're going to see there. Oh God, it's doing the yellow thing. Oh God. This PowerPoint used to do this. Sorry, we're gonna have to do this. All right, so your radial ulnar joint, right? That is going to be where these two intersect up above, right? You're gonna have your superior radial ulnar joint and your inferior, or your proximal and your distal. And so your radius is going to rotate around its head while it is articulating with your ulna there. And then the exact opposite is true on the other side. And so up top, you can see the radius is doing all the rotating up here, but then your ulna is doing all the rotating down here. And that's why this is a much thicker, fatter bone up top and long and skinny down here. And the exact opposite is true on the other side. So it's kind of cool. Again, this bone does a twisting motion. So let me see if I can find a good picture of that actually. Radius and ulna. Let's see a picture of the twist. There we go. So you can see it right there. So this pivots around this side, but it stays put. And then this pivots around this side while this crosses over here. Kind of fun. But not one that we spend too much time on. Then we get your wrist, which is, you know, you get a lot of joints in here, right? There's a joint, there's a joint, there's a joint, there's a joint, there's a joint. Tons of them, right? Where all your carpals are coming together and articulating with one another. So we sometimes call those your radiocarpal joints, which are basically where each of these little tiny bones is intersecting with your radius down here. But then we've also got all of the intercarpal joints, which are all the little tiny ones, where those bones are sort of sliding across each other. All right, any questions on any of those joints about how any of them worked, or anything that was super confusing, or anything that I moved through too quickly through that little first section before we start getting into naming some muscles? Getting into the long part here. All right, so let's go ahead and take a look at our upper back musculature first. So we are going to look at muscles in your upper back, but primarily what we're looking at today is shoulder motion. You got to remember, these PowerPoints can't exactly be perfect. You know, last time we were trying to do, you know, abduction and adduction and stuff. That works fairly well here, but it's not exactly perfect. So we're looking at the upper back first. So we are talking about the latissimus dorsi, the king of upper back muscles, or just back muscles in general, I should say. And so this is a huge pizza-shaped muscle. You know, it looks like 2 pizza slices on your back there. And it all comes together to attach right onto your humerus. So what's kind of fun about this muscle runs underneath your armpit. And when you're sitting in the anatomic position, it does not insert onto the back, right? It's not running from your back and inserting onto the back of this bone. It's actually running from the back underneath your elbow and inserting on the front of this bone. And that's really important to remember. So it doesn't attach to the back, it attaches to the front. So it concentrically accelerates shoulder extension, which is this motion here, right? That's shoulder extension. This is shoulder flexion. So your lats are in charge of that. It also concentrically accelerates shoulder adduction. So pulling your arms down at your sides like that. But remember, I mentioned it attaches to the front of this bone. So when it pulls into internal rotation, which is why when we see people who have rounded shoulders, right, and they have protracted shoulders and their, thumbs are facing inwards, right, they are experiencing tight latissimus dorsi muscles. So when you look at your lats, I have a feeling, oh, okay, good. You can see, oh, man, Ken Hub just rocks. I know they're green, but they just have such great pictures. You can see it attaches to the front of the humerus there, right? And then, you can see all this section in here. Notice how it gets becomes fascia, right? See this like a little white section down here, right? This is referred to as your thoracolumbar fascia, and it's where this section of your spine is kind of coming together with like the bottom lumbar section there. And the reason this is all fascia is because we actually don't want it to have too much mobility. We want it to be pretty solid so that it can help hold our pelvis together to our spine there. But if this gets too tight, this can cause a lot of like lower back stiffness and pain and things like that. Accelerates shoulder extension, shoulder adduction, and internal rotation. So then if we move away from the back and we start looking at the shoulders here, one of the first ones we're going to look at is your serratus anterior. This is those little like muscles that you see underneath the ribs, actually. I'm gonna look up a boxer because boxers have like the greatest serratuses. Look at that. There's Pacquiao, right? Look at those freaking serratus. That is huge for this little itty bitty muscle. And so boxers are a great example of this because your serratus anterior is actually in charge of this motion right here, which if you're a boxer, you're doing a lot of, right? And that's why they're the perfect perfect models for showing off your serratus anterior. So this muscle performs concentrically accelerates shoulder protraction. So its job is to move your scapula from the back of your body and rotate it towards the front of your body and back. Now, that may make it seem like, we talk about how many of our clients have like shoulder rounding all the time, right? So actually, really quickly, just talking about one of our most common postural distortions, right? On Friday, we talked, or on Thursday, we were with the knee, right? So we were looking at, pronation distortion syndrome, right? Pronation distortion syndrome, that is characterized by a foot turnout, right? So a flat foot and adducted knees. So we're seeing knees cave in, we're seeing feet flatten, right? So there's pronation distortion syndrome, one of our 3 most common postural distortions. But on Friday, we were getting into the hips. So we also talked about lower crossed syndrome, which is that anterior pelvic tilt, right? The Instagram booty. So we're often going to see like in lower cross syndrome, an excessive anterior tilt. Well, today we're going to see our 3rd most common postural distortion, which is not lower cross syndrome, it's upper crossed syndrome. And this is where you see a forward head posture and rounded shoulders. So that is upper crossed syndrome. I think living in the age of smartphones, I'm pretty sure all of us got this a little bit, myself included. So the reason it's called lower cross syndrome is because we had tight muscles here and tight muscles here, and then we had weak muscles here and weak muscles here, so it made an X. Well, guess what? We're seeing the exact same thing in our upper cross syndrome. So we see tight muscles in the upper neck back here, which actually rounds us down like this. And we see tight muscles down here, which are actively pulling us this way. Meanwhile, we are seeing weak muscles in the front of the neck, which should help us keep our head upright like this. And we're seeing weak muscles down below, which should pull our shoulders like that. And so this is what our posture should look like instead of this, right? The turtle head. So that is upper crossed syndrome. We've got pronation distortion syndrome, lower crossed syndrome, and upper crossed syndrome. So weak, weak, tight, tight. All right, so here's the thing. We know that like rounded shoulders are bad, right? And part of that is protraction. But oddly enough, your serratus anterior is one of our under active muscles. And that seems really surprising sometimes because you're like, wait. You just said we've got rounded shoulders and rounded shoulders are bad. and the serratus anterior rounds your shoulders. Why is this an underactive muscle? Why is this a weak muscle that we want to strengthen? Here's the thing we gotta look at when we look at the serratus anterior, right? It is attaching all the way down here to the bottom of your ribs. And I'm gonna pull up a better picture here. Serratus anterior. Probably gonna pull up the Ken Hub one. Of course I am. So there's the Ken Hub picture, right? And you can see it's attaching primarily to the bottom of your scapula. So here's the thing. This is an example of an underactive agonist being underactive because synergist muscles are taking over. Muscles that are supposed to help are doing too much of the work. So they're attached to the bottom of your scapula and they help round your shoulder forward like this. Notice how I was able to keep my head in place and I didn't have to round forward like this, right? The muscles that round you this way and pull your shoulders forward are your pectoral muscles. But the muscles that actually round your shoulders like this, that's your serratus. And so what ends up happening is your scapula, instead of rounding around the shoulder like that, the way it's supposed to, what ends up happening instead is that it rounds around like that. It tilts forward and drops like this. And the reason it tilts forward is because actually you can see it right here. See that little coracoid process? That is the attachment site for one of your pectoral muscles, which we will look at right here. I'm actually going to skip forward a little bit. Let me find it here real quick. That's your pectoralis minor right here. So see how your pec minor attaches from these three ribs right here and then attaches to your coracoid process? That pulls your scapula forward. So it's supposed to work together to protract the scapula, right? Concentrically accelerates scapular protraction, concentrically protracts the, I don't know why they wrote the sentence different, but it's the same thing, right? Your serratus anterior and your pec minor are supposed to do the same thing, but your pec minor pulls it downward like this because it's attached to the top of the scapula, so it rounds it this way, whereas the serratus is supposed to round it this way. So this is actually one of our underactive muscles here. So you do want to strengthen this muscle, which leads to the how, right? If I'm telling you to strengthen it and you're like, well, how the heck do I do that, right? Well, remember, it protracts the scapula. So what we need to do is we need to do motions like this, right? So one of the best exercises you can do is what's called the push-up plus. And basically, it doesn't involve actually doing a push-up. It just involves doing a little bit of scapular protraction at the top of a push-up position. So what you'll do is you'll go into a push-up position like this, like you normally would, and then you're just going to push like that, and then relax, and then push, and then relax. And that's the whole exercise. You're literally going like this, and back to neutral. Push, and back to neutral. If you have shoulder rounding, that is an awesome, awesome, awesome exercise to throw in to your movement prep, you know? I love to make my clients do scapular protractions and they'll be like, man, it feels like I'm doing a plank. And I'm like, great. I'm getting you to strengthen your core and we're working on your serratus. Yeah, what's up, Irene? Question.
Does your back stay neutral, Brad? It's
Yes.
just literally your shoulder, those two.
Yep,
okay.
Just your shoulders. Don't round your back. Yeah, that's a common. You'll see people when they relax, they'll drop their hips down. Right? Like, see how she's got a nice straight line here? Like, she's got a downward angle here, but this is all flat. So that's a really good one. You can also do like, I try to remember what we used to call it. I think we call it the reverse Mario punch. You know how Mario like hits blocks above his head? We would do that. And so like you can hold a dumbbell here and you can also do a push like this, going across your body. That's another way to strengthen your serratus. Or just boxing, like that's a really good one. If you're a scapular winger, by the way, meaning like when you do your push-ups, you have like one of these gaps here. I mean, this is obviously huge. That's a huge gap. Mostly because it's drawn, so I'm sure they're exaggerating here. But usually, like if you got really long arms and you tend to be like a scapular winger and you have like a gap between your back, this is a really good muscle to strengthen. Work on your serratus anterior, and that can help fill in this section back here, which is nice. Doesn't actually fill it in. There we go. Look at that. Whoo, scapular winging. Whoa. Oh, this person has palsy. Well, that makes sense. That does not count. There we go. That's your scapular winging.
My
So
my my brother has that, and he has like super long arms too. So that
does it?
makes a lot
Yeah.
of sense.
I'm a little bit of a, I was a scapular winger for years, you know, like I struggled with it until I put on a little bit of muscle. Not that there's, you know, a ton to brag about, but like, yeah, I was a scapular winger for years. So strengthen your serratus, that's a huge one. All right, next one we got to look at. So we've looked at scapular protraction. Let's look at scapular retraction. So we are going to look at your rhomboids. So this is another example of NASM being a little reductive, but this is your rhomboids major and your rhomboids minor. You can kind of see that they gave it a little bit of a difference here. See how they divided it just slightly? So there are like these little top skinny fibers here, and your, you know, much wider fibers here. They basically do the same thing. So we'll be kind of reductive here. These concentrically accelerate scapular retraction, and then they do scapular downward rotation. So you know, when you have somebody who rounds their shoulders, these are some huge muscles to strengthen. So they need to, you know, drive those that scapula back into a neutral position so it's not tilting forward. And then obviously they're there to kind of stabilize everything in your upper back as well. So your rhomboids, when you look at them, oh, come on, we were on a Ken Hub roll. You can see like this section right in here, right? So their job is to pull your shoulder blades back. Come on, Ken Hub, where you at? Where's the green? There we go. Really great muscles here, you know, definitely going to use those during like rowing motions, but basically, yeah, this little, you know, drawing here is perfect. Squeeze your shoulder blades together. It's the best cueing tip you can give your clients. So tell them what I used to like to tell people is like, I want you to imagine you've got a pencil and I'm putting it between your shoulder blades, and I want you to hold it there while we're doing our rows. And that way they can really just pinch those shoulder blades back. So that's your rhomboids. And then what's kind of funny is we're going to see your trapezius muscles here as well. And so take a look. Notice how those are in the same section. So you get your lower trapezius, your middle trapezius, and your upper trapezius. So those are your trap muscles, right? And they lay over top of your rhomboids. Yeah, what's up, Irene?
Yeah, for the rhomboids, the major and minor, what's the difference, Brad?
The major are the big ones, and the minor is the little tiny ones. There's not a huge difference. Technically, these top ones here, because of where they're attached at the top, that can sometimes contribute to that rounding. It can contribute to that downward rotation. But for the most part, because of these, look at how many more fibers are attached down below. They're going to contribute to downward rotation, or downward rotation, not upward rotation.
Okay, so the minor is just right there where you're pointing.
Mm-hmm.
That would be considered just that little bit.
The little tiny fibers. So okay. Don't worry about separating them, because you're not going to have to. So just refer to them, you know, rhomboids. That's a much easier just way to think about it. But technically, they do slightly different things. The only reason that would ever be important is if you had somebody who is like having some type of like pain in the back here and you needed to like massage something out, you'd want to know like where the origin is for the two separate sections. So that's your shoulder, like that's what pinches your shoulder blades together, but it's not the only thing that pinches your shoulder blades together. The next one we've got are the three trap muscles here, right? I'm actually going to pull up, there's a great picture online, upper, middle, lower trapezius. This is a great picture. I love this one because it's got the three different colors here. So you can see there's your upper traps, there's your middle traps, and there's your lower traps. And they all attach in slightly different places, right? You can see, I don't know, I've never seen this one. I like this one a lot. So you can see your upper section here attaching look at your scapula. It's running all the way out to the side and attaching here, which is why when it pulls, your upper traps does this, which is not so awesome, right? Because when we end up in this position, like everybody try this right now at home. Raise your shoulders up like this. Now raise your arms up as high as you can. Right? Can't get any higher than that, right? Whereas you should be able to raise it all the way up. So when you're elevated like that, what that does is that means your glenoid cavity, where your shoulder joint is, cannot abduct your arm. So now do the same thing. Pull your shoulders up, and now try to raise your arm up overhead this way. Stuck, right? Your arms are being pulled downwards. Again, glenoid cavity cannot move the way it is supposed to. So this is one of our commonly overactive muscles. This is on the overactive bad guy list on upper cross syndrome, right? So we see tight trapezius muscles, right? And then we're going to get to the pecs and the lats here in just a little bit. So tight lats, tight upper traps, and tight pectorals. Those are the muscles that are pulling the head forward and rounding us, right? What we want to strengthen, but to be fair though, let's look at the upper traps again here really quick. To be fair, see how these bottom fibers here, there are some bottom fibers. The reason this muscle is so overactive is because, we spend a lot of time doing this, and this muscle does try to help us this way. It's just not good at it. So like whenever our clients are trying to pinch their shoulder blades back, they're probably doing this, right? And they're like elevating at the same time. That's not what we want. So we want them to drive their shoulders down and back when they're pinching. Drive them down and back. That's an effective way to pinch your shoulder blades together. So this is definitely an overactive muscle, but it makes sense that it's overactive because it tries to assist these muscles when they're the ones doing that retraction. Again, muscles that have multiple jobs, and this one does, right? Muscles that have multiple jobs are often overactive muscles. So looking at your lower traps first. These are in charge of concentrically accelerating scapular depression. And it doesn't say it here, but they do also do a little bit of retraction. So your lower trap fibers, the ones that run from the bottom of your scapula down your spine this way, they're in charge. They are the exact antagonist to your upper trapezius muscles. If your upper traps do this, your lower traps do this. And that's why one of the really great exercises you can do is just scapular depression. And it looks really, really small, but basically L-sits are a really good example of that we really, really like. So literally just pushing down like that, right? Little retractions like that will drive your body upwards. This is called an L-sit. That's a really great exercise, but also scapular pull-ups. So a scapular pull-up is a very short range of motion, but it's literally hanging from a bar like this, and then you just pull and pinch your shoulder blades down. So you keep your arm straight, but you pull that and then relax, right? So you go from here to here and relax. It's small. It really isn't a large range of motion, but that is a great way to strengthen those lower trapezius muscles that run from the bottom of your scapula in that downward V right there. So that's your lower traps. This is a very commonly underactive muscle. By the way, another way to do this, actually just to look at it, look at the integrative function here. It isometrically stabilizes the scapula. One of the other great ways you can strengthen this are by doing what's called a YTA. So you can go into a hinge motion, and then you've got dumbbells, and you're going to go into a Y, and then go into a T, and then with your thumbs up, go into an A. And that right there, you're doing 3 motions where you're pinching your shoulder blades back. So that's a great way to strengthen your middle trapezius. But when you take your arms overhead like that, your arm creates this really long lever out here, and your lower trapezius has to like pull down to stabilize your scapula. So you may not be doing like you know, concentric action for this muscle, but you are stabilizing by, you know, holding it in place there. This creates like a lever traveling all the way from the bottom as it travels up your arm. Think of it as like, think of YTAs as doing like a wall sit, you know, but for this muscle here. You know, a wall sit's for your quads, right? Or think of it as doing like a plank for your lower traps. It's a really great exercise. So YTAs right here, just an awesome, awesome, awesome exercise. And so you just hinge and you go, why? This is, she's kind of doing an ITA, which is also really good. She's kind of like 90 degrees up this way, but you can go out to a Y movement, and then a T and then an A. This is also sometimes referred to as ball combo number 1. You'll see it listed as ball combo number 1 in your book, where you do it in a.
You can do it. You can do it with resistant bands too, right?
Yep, absolutely. You would just want to tie it kind of at a 45-degree angle away from you this way. So you would pull it Y and then into a T, and then you pull into an A like that. But yeah, you can totally do it with resistance bands. Trust me though, pick a really light band. This is a deceiving exercise. Like these are probably like little 5-pound weights. And I'll have like, you know, big burly dudes, and I'll give them these little 5-pound weights, and they're like, I can do like 30 on lateral raise. I'm like, trust me, like you're gonna want 5ers. It is harder than it looks. So that's sometimes referred to as ball combo number 1, or it is sometimes referred to as a YTA. So that's your lower trapezius. Then we get your middle trapezius, which also gets worked during a YTA, especially the T part. And that is scapular retraction. So your lower traps and your rhomboids, did I say lower? I meant middle. Your middle traps and your rhomboids are basically the same thing. They just attach in different spots. So you can see like this one's running here, and I'm just gonna scroll up to your rhomboids, right? This one's running in here. It's funny, they always show, you know, whenever you look at like a machine, rhomboids, you know, whenever you look at like a rowing machine, not a rowing machine, shoot, what do they call it? Because when I think rowing, when I'm gonna pull up rowing machine, it's gonna pull up the cardio. I actually mean seated row machine. Yeah. Whenever you see stuff like this, like I'm sure we'll see a picture in the background. Yes, there's Cydex, right? See the little like sticker back there? Do you guys see that? You can see it behind the back of his head there. You know, they always put a picture of like what muscles are getting worked on at machines, and they always show pictures of rhomboids, but they never show the picture of the trap muscles. And honestly, the trap muscles are arguably the most important. See there, little picture. Guaranteed it's like shaded in with like, these are the muscles you're working. I guess maybe not now. Oh, there we go. Stickers, right? Anyway, that's so unimportant. But that's what you're working there. You're working your middle trapezius fibers. So now we know the different sections, right? Our upper traps do this, our lower traps do this, and our middle traps do this, just like your rhomboids. But again, we understand like why all, you know, this upper trap, because it is attached there in the middle, it's just very commonly overactive. Not to mention like this is a muscle that, you know, it actually kind of helps expand your rib cage a little bit. And so like during like really intense stress situations, your upper traps actually sort of try to help you breathe. So you're like, which is not awesome, by the way. That only leads to overactivity here. And then when you have clients that breathe like that, they're doing shallow chest breathing instead of diaphragmatic breathing. And that shallow chest breathing leads to like more stress hormones getting created, which guess what? Leads to more shallow chest breathing. And so it creates what's called a positive feedback loop, which is really bad. So you'll get people who have tension headaches and things like that. Really quickly, the other things that this does, by the way, it is also in charge of lateral flexion. So moving your head side to side like this, that also is your upper traps. And it also does help a little bit in cervical extension. So it's actually assisting in motions like this, which is another reason why I think Irene, you might remember this in particular. have you had your hand up? Did I answer your question?
Yes, you did.
Okay. Sorry, I didn't unclick it. So you remember when we were doing Supermans at the park? And I was like, don't raise your head up at the same time. People love to, you know, when they think of exercise or people when, you know, you ever hear trainers say like, don't put your hands behind your head to do sit-ups anymore. Like trainers stop telling people to do that. They'll say like behind the ears or they'll go here. The reason we do that is because we don't want our clients to pull their head down like this, right? All that's doing is like strengthening the muscles that create that shoulder rounding, right? Well, the same thing is true, you know, when you get a client who's doing Supermans, you know, they'll lift their arms up and stuff, but then they'll also do like this big head movement here. And it's like, no. I'm just trying to work on your low back. I want you to pull your low back. I don't want you to move your head. That's strengthening these cervical muscles here, which are already overactive. So just keep your eye line forward. You can, if you want to do more neck movement, you can tuck your chin like this, but I don't want you to do this, okay? Because all that's doing is strengthening those upper neck muscles that are already overactive. So look at all that your upper trap does, right? Scapular elevation, cervical extension, lateral flexion, and lateral rotation, right? It's like lots of jobs, overactive muscle. Go back to our lats, right? Shoulder extension, shoulder adduction, shoulder, lots of jobs, overactive muscle. It's a very common thing that we see. The more jobs a muscle has, the more likely it is to be overactive. So those are some of our bad guys, right? The upper traps, and then we have some of our weak muscles here, lower, middle, and rhomboids. So these are actually, and serratus anterior. So this is like your underactive very commonly, and then upper traps and lats, those are very commonly overactive. Then we got some more overactive muscles, but it's the muscle that every guy on the call has been waiting for. I feel like this is every guy's favorite exercise. Like, you know, it's the bench press muscles. We're looking at our pecs. So pectoralis major and pectoralis minor. I do like the pecs. They're a cool muscle. If you look at your pectoralis major, it does a really cool twisting motion, which I think is really fun. You can see it kind of creates this little twist in here before it inserts onto this bone. And so your pec major, and you can really see it in this picture. I love that little twist right there. It looks like bow tie pasta. It accelerates shoulder flexion, which may be surprising, but to be fair, it is only the upper fibers that do. Look at how, like, you can see your upper fibers right here, right, as they run down. That actually assists in shoulder flexion. So raising your arms up overhead. And that's why, like, you know, it's always a good idea. You can even feel if you place your hand like just under your collarbone and you do like a front raise. That's a great way to, you know, this is why it's so popular amongst bodybuilders. They love those front dumbbell raises. It also does horizontal adduction. That is its main job. So it is mostly in charge of this movement here, the fly motion, right? When I'm doing a chest press, I'm bringing this bone across my body like that, right? That's horizontal adduction. That is the pectoralis major's main job. So a bench press, a chest press, a push-up, right? All of those things are shoulder horizontal adduction. But it also does internal rotation. So it works with the frickin' lat, which is already overactive, right? To do that shoulder rounding motion, right? That rounding of the shoulders this way so that we're all, you know, bringing our thumbs together around the front of the body. Not awesome, right? So pectoralis, and look at how large this muscle is, right? I'm trying to really draw, I'm trying to really kind of lay it on thick here when we're talking about that internal shoulder rotation, because look at how large this muscle here is, right? Shoulder internal rotation. Now, let's go up here and look at your lats, right? Huge muscle, right? Also does shoulder internal rotations. You got these giant muscles in charge of internal rotation. And we're about to go get to the rotator cuff in a minute. And we're going to see the littlest, tiniest muscles that are in charge of like working against frickin' Goliath over here. It was literally a David versus Goliath situation with your giant internal rotators versus these little bitty external rotators. So that's your pectoralis major. Then we also see your pectoralis minor, which is underneath your pec major. And it's the section right in here. You can even feel it. If you really dig in, you can sometimes find that coracoid process down below your scapula. So you're below your collarbone, you really dig in right here. You can sometimes feel like, oh, and it is a very, very, very tight muscle. This is also in charge of protracting your scapula. So you've got the pec major creating internal rotation, and you've got your pec minor creating shoulder protraction. And so we're just gonna sit like this for the rest of our life in terrible posture. No, we're not. So that's your pec minor there, but it does not assist. And by the way, notice how they both insert onto different spots, right? They may be in the chest, but this one's inserting onto your scapula. Your pec major inserts onto your humerus, right? That's why this pec major moves your arm and your pec minor moves your scapula. Both overactive muscles. All right, then we got our deltoid muscles. Let's get into the shoulder here. So your anterior deltoid, anterior means front, right? So this is on the front of your shoulder here, and then it runs and attaches to your humerus. So it concentrically accelerates shoulder flexion. And there it is again, internal rotation, right? Another muscle to round our shoulders forward and give us that internal rotation. So anterior deltoid here on the front, you know, it's in charge of that shoulder flexion. It actually does assist a little bit here, just not very well. So anterior delt, then we've got your medial delt, medial because it's on the, actually, this is kind of a weird one because it is actually way more lateral. This is always very confusing because you're like, whoa, 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 that's so lateral, right? Like medial would be on the midline. Your deltoids are about as lateral as it gets, right? Like it's about as far outside the body. But the reason it's called your medial delt is it's the middle one. But in my opinion, that is the worst labeled muscle in your body. So that's your medial deltoid. It's the outside one. And so like the, you know, when the really meaty part of your shoulder on the outside, that's the medial, and it's in charge of abduction, right? So it's in charge of raising your arms away. So if you want to strengthen the front of your shoulder, you're gonna do this. If you want to strengthen the side of your shoulder, you're gonna do this. And then we get your posterior delt. And finally, we've got an external rotator. So this one's in charge of horizontal abduction. Look at this little tiny muscle. It's got to work against your giant pec muscles that we all love working so much on that freaking bench press, right? This posterior deltoid is in charge of pulling our shoulders back this way, right? So you got the rhomboids, which are pulling the shoulder blades back. You got the middle trapezius, which is pulling your shoulder blades back. But your posterior delt is pulling your humerus back like this. And so like that's why, you know, there's a difference between just doing a reverse fly and doing a reverse fly with a pinch, right? So don't forget to pinch those shoulder blades back while you're doing it. That's a big part of the movement there. So it's in charge of shoulder extension. So it does a little bit of this, but it also does external rotation and horizontal abduction. And then we got the two teres muscles here. So I separated these out slightly because your teres major is a little more exposed compared to all these little rotator cuff muscles that we're about to get into. So this is your actual rotator cuff here. Your teres major is not officially part of it. So you're going to see your teres major and your teres minor. Teres major is right here. It runs from the bottom of your scapula and it inserts onto the front of the humerus, okay? Your teres minor runs from the bottom of your scapula and inserts onto the back, there we go, the back of your humerus. Front, back, front, back. Major, minor. That means that they do exact opposites of each other. They are antagonists. Your teres major is another freaking internal rotator. So it concentrically accelerates internal rotation. It also assists in adduction and a little bit of shoulder extension, right? These movements that, hey, guess what? We kind of walk around the world most of our time. You know, none of us are walking around the world like this, right? Like, hi, how you doing? I'm here to do my grocery shopping, right? And be like, okay, you're also here to get arrested. Versus like your teres minor, which is in charge of pulling you this way, right? So your teres major is in charge of this. That's that internal shoulder rotation. Your teres minor is in charge of this. That's that external rotation. That's why we've got them kind of separated by a little gap here. So shoulder internal rotation, teres minor, and these are the muscles associated with your rotator cuff, right? Your rotator cuff, these are the muscles that are supposed to help rotate your shoulder around, right? These pivot motions. We are going to see your teres minor, which accelerates external rotation. You're going to see your infraspinatus, which is this muscle. The reason it's called infraspinatus, remember how this little ridge back here, infraspinatus. Remember that ridge on the back of your scapula is referred to as the spine of the scapula. That is inferior to the spine of the scapula. So this is actually the meat running on the back of your scapula there, and it grabs the back of the bone so that it can rotate it this way, right? So concentrically accelerates shoulder external rotation. So again, notice how I'm not changing it. Look at how the muscle's changing, the picture's changing, but notice how the text has not changed, right? Teres major, infraspinatus, both of them do external rotation. Now, we do have one rotator cuff muscle that is internal rotator, and that is your subscapularis, which is totally on the opposite side of the infraspinatus. Subscapularis. And so you can see that one. This one's actually kind of hard to see. You can see it here. So notice how this is the back of your shoulder, and it's like it's a webbing that runs along the scapula, right? Well, this is also a webbing that runs along the scapula, but it's doing it from the other side of the bone. So, you know, if you were to pull a scapula, you know, off somebody, you would find muscle on the front and you'd find muscle on the back, right? And so like, actually, there we go. That's a good picture of both of them side by side. So they're there to be situated like this, and that way they can pull and rotate your arm like this, right? If you think of, like, let's say, I want you to imagine this is like my shoulder as it's resting in my arm, right? They're here, and they're doing that. So that is your subscapularis, right? So infraspinatus, subscapularis, you know, these are both external rotators. This is your internal rotator that is part of your rotator cuff. Then you've got your supraspinatus. And this is actually a little itty bitty muscle. You can barely see it here. It's superior to the spine of the scapula. It's there to help in that abduction, right? You got that big honking deltoid muscle out here that's like pulling your arm this way, and then you get your supraspinatus. We're like, I can help, you know, and it's there to also assist with that. So I'll pull up a picture of that one actually. Supraspinatus, superior to the spine of the scapula. And so that one's right here. I want to find a good one. Oh, Ken Hub's gone. All right, there we go. That's a good picture of it. It runs underneath there's oh, by the way, this is a great angle. Do you see, there's that acromion process I talked about. Remember how I said it hooked around the front of the body? That's the freaking angle I was looking for. Look at this. This is great. You can really see it hook around the front. There's your collarbone. So this muscle runs underneath it, right? Along that top ridge there. Man, I've never really like missed my skeleton more than right now. Like the skeleton we have in the classrooms. Oh, I remember this. We're about to run into a weird NASM glitch. So that's your supraspinatus. And then look, we're in the arm musculature. They put a picture of the calf. I don't know why this happened. That's the wrong photo. That is very clearly not your arm. But anyway, before we get into the arms, do you guys have any questions about those rotator cuff muscles? Yes, Irene, what up?
Yeah, can you show us an example of the subscapularis and supras? The last two that you just went over.
Yeah, totally. So here's the supraspinatus. There's the spine of the scapula, right? It starts superior of it, right? But your subscapularis is right here. It is underneath, technically. It's attached to the bottom of it, right, of the scapula. So the reason it's called the subscapularis isn't because it's like below it. That would be the, they would, if it was below it, they would call it like the infscapularis, because that would be inferior. The reason it's subscapularis is because it's if you look, if you're touching me, like if you're patting me on the back, right, you would be patting the bone. You would have to go underneath the bone to be able to touch my subscapularis. It's deeper, right? It's closer, it's underneath it, but it does run to the front and attach to the front of my humerus here. So you, so there's your infraspinatus, which is below this like spine. That is what you can literally, if you rub your scapula here, I mean, for the most part, you're rubbing like, you know, your mid traps and like probably your rhomboids and stuff, but like on the shoulder blade itself, right? That's the infraspinatus. But if you were to like pass to the other side of the bone, go from here and just flip around the back, that's where you get to the subscapularis. Does that make sense?
Yes, it does.
Cool. And then the supraspinatus is superior to the spine of the scapula. So that's the supraspinatus. And then the infraspinatus is below it, like I said. And then just because I need to do them again, because I love bringing them up, there's the teres. Actually, look at this. This is a great picture. Look at this. There's your teres minor, right? And so it's running right there. Your teres major would start in the same spot, just below it, actually, about here. And then rather than tying in the back of the humerus here, your teres major would attach to the front of the humerus, right over here. So that's your rotator cuff, right? These muscles that are there to help you stabilize your entire, you know, arm as it's attached to your body. And remember, the reason you got to have all these little muscles here is because this is a false joint. There's, you know, the only thing holding your entire arm, the only thing holding this whole thing on to the rest of your body, right? This giant bone right here and this bone down here. The only thing that holds it on is this little joint right over here, your collarbone. So that's why we have so much, you know, musculature holding this whole thing on. And that's why it kind of looks like, I mean, if you look at me, right, it kind of looks like most of my muscle is in my upper body. You know, we think of like, look at like the way they draw cartoon characters. You know, you look at like Kronk from Emperor's New Groove. He's the best example because he's got that line where he's like, I'll warn you, I'm very hard to fit. I've got a 64-inch waist and a 22-inch waist. You know, this giant V shape, right? That's like a classic friggin' huge upper body. That's not even like, we have 60% of the muscle in our entire body. If you were to like pull all your muscles off and just throw them onto a scale, 60% of your muscle is in your legs. It just doesn't look like it because this is so like wide and spread out, but the muscles in your legs are thicker. So there just isn't that much muscle to hold these little tiny bones on your arms, you know? Yeah, question.
You said, yeah, you said 60% of the muscles are in the legs. And women
not
have
number
more
of muscles,
muscles in the
not number of muscles, poundage of muscles.
Oh, pound. Okay.
Yeah.
So the weight of the muscle.
Yeah. Like, I mean, I'm picking weight because, you know, that's like your mass. Surely there's somebody out there who, you know, their upper body weighs more. But I mean, like your motor neurons and like how much muscle you have. Like if we think of like your strength and where it can come from, 60% of it's in your legs.
Oh, and
Right?
I think you mentioned like women have more muscles in their thighs, or
Yeah, so because of women's like because of like the way their pelvis is shaped and stuff, yeah, women, like if you look at like let's say you had you know, here's a weird example. Let's say you had a 100-pound female and you had a 200-pound male, right? Yeah, the guy weighs twice as much as the lady does. And then you were to look at like how much that 100-pound woman could squat versus like how much like a 200-pound man could squat, right? The man would squat more. But if you were to look at like the percentage of like his body weight versus his weight he can lift, and you would do the same thing for like percentage of like squat weight that the woman could lift, she would have like a greater percentage of like leg strength to body weight ratio compared to leg strength to body weight ratio a man would have. But men will have a greater arm and upper body strength to body weight ratio compared to women. So if you think of it that way, you could go like most of women's strength is in their legs, whereas most of men's strength is in their arms and upper body.
Oh, that's a great, thank you for making it so clear. It's probably because they bear children, right?
I think so. I think it's that and like the, yeah, like the shape of the pelvis and like all that stuff coming together.
Wow.
Yeah.
We kick
I mean, like,
ass.
don't get me wrong, like men have the deadlifting, record. Like, don't get me
Right.
wrong, like that's still a thing because of like also like a greater distribution of type 2 fibers. But if you look at like body weight to weight lifted ratio, the gap is totally different, you know?
Got it.
Yeah, kind of fun. I love stuff like that. All right, I've left it on this slide long enough. Let's get Nassim's goof up off here while I try to remember how to use the English language. So looking at your arms, the biceps brachii, the guns. This is your ticket to the gun show. You guys see my beach ball? It's about this big, might be somewhere over there. So that's your biceps brachii. That's the one everybody's always trying to show off. It concentrically accelerates elbow flexion, but it also does supination. It is also in charge of turning your palm up this way. And to be fair, your biceps actually assist a little bit in shoulder flexion, weirdly enough. They are there to help a little bit in raising that arm up overhead. However, it's not what it's known for. What it's known for is elbow flexion. So that's your biceps brachii. And take a look. The reason it's your biceps, similar to your hamstring muscles, right? It is two separate fibers. You've got one attaching to that coracoid process, the same spot that pec minor attached to, right? There's three, it goes from these three ribs to attach to here. And then it also attaches to the outside of the shoulder there. And that's why it can do the shoulder flexion with these parts here. And it can also do the supination by having the rotary movement there. Now, biceps brachii. I'm not going to pull up a video of it because it's horrifying, but this is one of the reasons why, like, don't get me wrong, a mixed grip deadlift, right? So that's where you're doing one palm up and one palm down. 100%, I will be truthful here, it will 100% help you lift more weight because your grip will be much, much easier. So if you're somebody who does deadlift and you find that you're like doing this thing where you're like barely holding onto the bar towards the end of your reps, this mixed grip will help you. But I do not like it. And here's why. It puts this muscle into a stretched position while leaving this one normal. And then you are also with a straight arm, which is the exact opposite. So now you're in this like contracted position because you're supinated, and you're in a stretched position because you're in elbow extension. And what ends up happening is you are overstretching the crap out of this tendon right here. And it will often result in I shouldn't say often, but it can result in a biceps tendon tear. And it is horrifying because you will watch this basically just bulge like crazy as the muscle basically curls up on the inside of the arm. Don't look it up, it's awful. So that's the biceps brachii. Triceps brachii, totally the exact same thing, except, opposite. And so it runs from the back here. There's some fibers, and there's some fibers right over here on the scapula itself. So on the humerus and on the scapula there. And that is going to do elbow extension. So the fibers that are running on the humerus here and attaching to that ulna. And then it is also going to do a little bit of shoulder extension. And that's why, like, when you're doing tricep exercises, there's kind of two different versions out there, right? You can do tricep exercises where you do this, where you're just pushing straight down. That's like that classic cable tricep extension. But then there's also the versions where you're up in a position like this, doing like overhead motions. And what that does is that puts you into a stretched position before you use your triceps, which is putting you into shoulder flexion. And that means that you're going to be working these upper fiber parts of your tricep Whereas if you do this version and you are in shoulder extension while doing your triceps, you're going to work these lower fibers down here. So it depends on what you're trying to do. Are you trying to fill in these fibers in the back of your elbow here? Well, then you want to do this tricep extension. If you're trying to fill in these fibers up here, you kind of want to be in this up overhead motion there. Both are good, you know, they're just different. That's more of a bodybuilding tip for you guys, you know, depending on where you need to fill it in. You can tell that I really like overhead tricep movements because like this is a little more filled in, and I really dislike the cable ones. Mostly because I just also don't like doing a lot of arm work. You got your brachioradialis, which is actually running from your humerus down to your wrist. So this actually is also in charge of elbow flexion. This is the one where if you've ever been doing really heavy curls and you feel that tightness down here in your forearm, that's your brachioradialis. And if you ever get that, like, you can even feel like the tendon there, it's really like kind of thick. That's your brachioradialis there. And if you ever get like that, you know, sometimes you'll get like that really bad achy sensation. You'll feel like right along the outside here. That is also your brachioradialis. So this is where you need that massage. Irene, you remember Kenny?
Yes, yes.
Remember how he was always massaging his elbows?
Yeah.
That guy, I told him, I was like, Kenny, you gotta go do some more tricep work and you gotta leave your biceps alone. Because he just had a perpetual like elbow bend. And that's because he had a super overactive brachioradialis. He spent all of his time doing curls, which is why Kenny had fantastic arms. Kenny's arms were huge. But I told him, I was like, you gotta work on those triceps. You gotta like get this to relax. And that's why you'd see him doing, like, he'd just be rubbing here all day.
Yeah, and his feet turned outward, like his toes.
He did, yeah. He had a knee cave out situation, which is also fairly rare. But yeah, he was like a foot turner outer, and he had like a supination thing. He would rest on the outside of his foot instead of the inside, which you don't see very often. You don't see a lot of foot turner outers.
Yeah, I used to do a lot of bicep curls and things like that, and I found out if you don't balance out with the triceps and the biceps, then you'll lock up. Like it hurts. Swell up. It hurts. You know what I'm saying?
Yeah.
Yeah, you won't be able to flex it, you know, forward, like straighten it out. It'll be just stuck.
Yeah.
So you'll be just stuck with a curl.
Dude, you know what's funny? I used to I remember one time I was at the gym. I've still never explained this. I still to this day cannot explain what happened. But one time I was lifting, I was at my school and I was lifting, and I was on a bicep curl machine, and I was just maxing out like crazy, and I was like, I was pulling really, really hard. And I looked down, and on my right bicep, I got this little bubble. Like it was so small. It's like the head of like a pen, but it was literally like an air bubble. And I was like, what is that? And when I was done, I relaxed and I like bent my elbow and I made the bubble again. And I poked it and it was like, and it like popped and just went through my arm. And it felt like somebody had injected my arm with like really like ice water. And I was like, whoa, weird. And I was like, oh my God. And, you know, it wasn't like an injury or that painful or anything, but it was the weirdest sensation. And the next day I woke up and I could barely straighten my arm. I was like, oh my God. Because this muscle was just like, it was just like stuck. I don't know what that was. Like, I know plenty about anatomy. No idea what a bubble in your arm is. No clue. So anyway, this is another one, by the way. So these are your elbow flexors, your biceps brachii, your brachioradialis, and your brachialis. And this is kind of like a thinner muscle at the very bottom. This is also in charge of elbow flexion. So your brachioradialis attached here, your brachialis attaches here. So you can see one is on your radius and one's on your ulna. And that's also an elbow flexor. There's your neck musculature, which is also a picture of the calf. So dumb. All right, so that's your, you got three bicep muscles, right? Versus your one triceps muscles. But, you know, bi for 2, triceps for 3. That's why, you know, it's able to kind of handle it. It's got more separate fibers. So you'll notice we don't have some of these agonists written out here. We actually don't have these prime movers in our notes. It's because we're getting into the cervical spine and neck area, which we are going to do tomorrow. So I'm going to mention it because it does have some scapular movement today. And it is related to your scapula, which we just spent a whole bunch of time talking about. But primarily, we're talking a lot about neck stuff here. So we're not putting them in your notes until tomorrow. So the first one's your levator scapula, which is in charge. This is another muscle that gets very overactive, and this is a very tight muscle in a lot of people. This is going to accelerate cervical extension. So that's this, right? It's also going to do lateral flexion, just like your upper traps, right? And it's going to do ipsilateral rotation. So my right side will contract to contract me to my right, and my left side will contract to contract me to my left. And it actually assists with downward rotation of the scapula, which is a bad thing, right? That downward rotation, the rounding. So levator scapula, another really commonly overactive muscle. This is one of the causes of upper cross syndrome. Remember I said it was tight to tight? This is that X, right? This is the tight muscles. So right here in the back, pulling you down this way. Just like your upper trapezius. Then we have your sternocleidomastoid here on the front and running to the side, right? Also very overactive, right? It is in charge of, again, cervical flexion. So that's, I'm sorry, cervical flexion. We were looking at extension before. So that's this, right? And it does rotation and lateral flexion. So sternocleidomastoid, levator scapulae, and upper trapezius are all very overactive muscles that we will be looking at tomorrow when we sort of finish our conversation about upper cross syndrome. Okay, reviewing our movements really quick before we go through our agonists. So abduction, right? Also known as like protraction of the shoulder. So protraction of your shoulder blades is this way. Retraction of your shoulder blades is this way, right? Then we have got downward rotation, which is this, right? Dropping your shoulder blade down. And then we got upward rotation, which is that, raising your shoulder blade up. We've also got elevation, which is here, versus depression, which is here. And all the agonists that are in charge of those, the ones that perform scapular protraction, so again, shoulder forward, right? That's going to be your pec minor and your serratus anterior. The serratus anterior is actually kind of a good guy in this case. I know, again, I always bring this up, but like, you know, we would say like, wouldn't we want to strengthen because we already have too much rounding? The thing is, look down here, your serratus anterior does scapular upward rotation. So yes, it does do protraction, but we want to strengthen it so we can get better at upward rotation. We can get better to getting our scapula back in the position it's supposed to be in instead of rounded like this. So serratus anterior is a weak muscle that we want to strengthen. Pec minor though, leave that freaking thing alone. Stretch that out. You know, this is an overactive muscle that's causing rounding. Scapular retraction, pulling our shoulder blades back. Main muscles here are your middle traps, so your middle trapezius and your rhomboid muscles, right? Here are the rhomboids. There's the middle traps. That's about from here to here. That's this section here. Whereas your upper traps are sort of this section here, and your lower traps are this section here. Scapular upward rotation. I already talked a little bit about it, right? Serratus anterior, right? So again, upward rotation is tilting it like this. So serratus anterior is huge. Lower trapezius is huge, right? Those fibers that are attaching to the bottom of your scapula to pull them down like that. And the middle trapezius is there to help as well. So these are all three muscles that we really want to strengthen. Versus our scapular downward rotation, which is going to be your pec minor. So from those 3 ribs right there attaching to the scapula to protract it forward. The one you are going to see here is rhomboids, but Irene, you were asking earlier, difference between rhomboids major, rhomboids minor. Those very top fibers, they do a little bit of downward rotation, but again, like nothing to write home about. It's on the list, but like it's really just not what it should be known for. Scapular elevation going this way, right? All bad things. We're so freaking good at this. People doing shrugs, stop doing shrugs. You know, Jesse, no more shrugs, right? So we love this. This is that levator scapula, way overactive. Upper trapezius, way overactive.
Love shrugs.
I know we love shrugs, but we got to stop them. So, and then we see the rhomboids there as well. So scapular elevation, definitely something we do not need to work on. But scapular depression, we could use plenty of that. So L sits, right? We're pushing down like this, or that scapular depression pull up, right? Both those are really great. Lower traps, pec minor, right? Even dips. I'm not a huge fan of dips because it puts a lot of stress on the shoulder, but if you're somebody who can do dips and you don't feel a lot of stress in here, go for it. Dips are great. That's, you know, that scapular depression. Then we got all the ones, oh, there's the dips. Oh, there's the yellow thing again. Stop doing the yellow thing. So then we look, that's our scapular movements, right? Then we have our shoulder movements, right? Shoulder joint, that's shoulder, wait, where's flexion? Okay, well, shoulder abduction and shoulder adduction. We also see, there it is, shoulder flexion versus shoulder extension, right? Then we see horizontal adduction versus horizontal abduction. And we will see internal rotation versus external rotation, right? So those are our shoulder joint movements, right? So your shoulder flexion, so that's this one. That's going to be your anterior deltoid and the upper parts of your pecs. Then we're going to see shoulder extension going this way. That is going to be your teres major, right underneath back here. Your latissimus dorsi for sure, right? There's your big lat muscles. And then there are some lower fibers in your pec that do it, but again, not what they should be known for. Then we got abduction, right, going this way. That's going to be your medial deltoid, supraspinatus, so top of the rotator cuff, and a little bit of the pec major is there to help as well. Again, nothing to really write home about. It's not great at it. Then we got adduction, right, which is really what a pull-up is, right? I'm adducting my shoulders down, right? So your lats, huge on a pull-up, right? This is why your lats get a lot of work when they're doing that. Teres major is there to help with that. And then again, the lower fibers of your pec major. NASM's not going to have you separate your pecs, by the way. Like technically your lower fibers and your upper fibers are total opposites of each other, but NASM's not going to have you, they're not going to ask you about that. Internal rotation, right? Look at this freaking list. It's so long. Internal rotation, that's your lats, it's your teres major, it's your subscapularis, and it's your pecs, right? Versus external rotation, which you got this short little list, infraspinatus, teres minor, and posterior deltoid. No wonder we're so good at this and we struggle with this, you know? And there's the, oh, sorry, I moved to external without showing it to you. There's the externals, right? Then we've got horizontal abduction. So horizontal abduction is pulling this way. Horizontal adduction is pulling this way, adding to your middle, pulling away from your middle, right? Abduction, that's your posterior delt, no surprise there, right? That's the reverse fly. Medial delt there to help a little bit, but infraspinatus and teres minor are there as well. There's that little teres minor, little itty bitty muscle. There's that infraspinatus underneath, inferior to the spine of the scapula. Adduction going towards, right? These are all the ones we like to work. This is going to be your anterior deltoid, so the front section there, as well as your pec major, which is the real main heavy workhorse for horizontal adduction, right? When you think of like push-ups or bench press or things like that, that's why it's your pecs. There is a little tiny muscle that we're not mentioning here. that didn't get any love through this whole PowerPoint, but this is called your coracobrachialis, little tiny short muscle right in here. It's actually part of your biceps, but again, not something we're really talking too much about. Lastly, we've got the elbow flexion, elbow extension. We've got pronation, which is palms down, versus supination, which is palms up. So your biceps and your brachialis and your brachioradialis, those are all in charge of elbow flexion. And then your triceps are in charge of elbow extension. There is this other little tiny, I forgot about this little muscle. Your anconeus is this little short muscle back here. It's the pectineus of your, I'm sorry, it's your, oh shoot. I'm actually forgetting the name of it. Nope, can't remember the name of it. It's this little tiny muscle in the back of your knee. Little stabilizer that's there. That's your anconeus. But we never talk about it. Then you have got, for pronation, the big one that we want you to know is your brachioradialis, but you do have your pronator muscles there as well. And then supination, that's your biceps muscles. And then we got the wrist stuff, which I said would be at the end, but it's all your carpal muscles. NASM's not going to test you on these, but they did put them in the PowerPoint, so they didn't even take the time to un-yellow them. I think that's why, actually. I think when you see yellow stuff like this, I think that's actually, I have a feeling we got like an early version of this PowerPoint. Like, I don't think they were done with it. That's why that calf picture is there. Like, I think they were using as a placeholder. I don't know. But there's a whole bunch of little tiny wrist muscles there. You can go over them if you're interested in it. But honestly, it's really never going to come up. So that, honestly, guys, that is the shoulder and the elbow joint today. And that's also like the scapula and the shoulder joint. So technically I did 3 joints today. Questions, comments, concerns. How you guys feeling?
Yes, Brad, the medial deltoid, can you show me an example of what?
Yeah, let me pull up the share again. So your medial deltoid, right? That's the middle deltoid. So medial deltoid. The dumbest name.
Posterior is for extension, right?
Oh,
shoulder extension.
Yeah. So posterior is abduction. Anterior is shoulder flexion. Sorry, 1 second. I need to sneeze.
Right. Bless you.
And then medial, thank you. Medial is abduction. So medial is on the side. Anterior is on the front. Posterior is in the back.
Anterior is the front.
Yep.
Posterior is back.
Yep.
And then medial, I'm sorry, I just can't seem to get a grasp on. Medial is
middle in this case. It's weird because it's like I said, it's the worst named muscle in the body because medial means close to the midline.
Yes.
It's like on the outside. Lateral is farther away. But medial sometimes means middle. So it's your middle deltoid. It's between the anterior and the posterior. It's in the middle. It's a it's the worst named muscle in the body. Like, it's so confusing. But that's where it is. It's the middle deltoid.
Okay, but I think you also mentioned that it's very lateral, right? Although it is
extremely lateral. It's about as lateral as it gets, you know? Like, in fact, it is the most lateral it gets. I mean, I guess maybe you could have wider hips than your shoulders, you know, if you got like some real meat on your thighs. But like, for the most part, this is about as far outside the body as it gets.
Right. Okay, cool.
It's literally as lateral as it comes. But yeah, it's motions like this.
Okay.
But yeah, any other questions? That was a good one.
The flashcards. I got a used printer and I'm in the process of figuring it out. Is that something that we can turn in before we're done with this PFT 119?
Oh, totally. Yeah, you can even do it by the end of the mod. Like, some people don't even get it done because like a lot of people are just doing it as it comes, and it's like tomorrow's our last day of muscles. So like you'll finish the list tomorrow. So, you know, like some people will have it done tomorrow, some people won't. You know, like, I don't expect you to necessarily just have it to me by like, tomorrow or anything.
Okay.
If it takes you a few days, that's totally fine. It's meant, and some people are gonna save it. Some people, I'll have people, who don't need extra credit, and then they'll get further along the program. You never met this guy Dayton, but Dayton had like perfect attendance until he got to capstone, and then he was like, I got all this free attendance, and then he just started like missing class because he could. And we were like, ugh. But I mean, you're allowed to. So he would do those extra credit assignments and like go to Six Flags for the day. Don't do that, but you can do that.
I need it for me to, just get used to the terms and.
Yeah,
Whew.
it's a lot of terms, especially when you get stupid stuff like medial deltoids.
Yes. All right. Thank you.
Yeah, of course. Jesse, Noel, Robert, how you guys feeling? Any questions?
No, I'm cool. I got you.
All right.
Get over here, man.
Fair enough. All right. Well, let's get you guys on to the rest of your day, and I will see you guys tomorrow for cervical spine. So we'll get into the neck.
Night at the Roxbury.
Right, seriously, yeah. I'm just gonna be doing this on camera all day tomorrow. Yep.
Thanks,
All right,
man.
guys. See you tomorrow.
All right, you guys have a good one.
You too, man.